Hi, everybody. It's Renee again. In this voiceover, we are going to cover immunizations. Here's our outline for childhood vaccinations. We are first going to talk about the diseases that the vaccines prevent, what a vaccine schedule is like and how to find it, how we make sure that these vaccines are safe, and then we're going to talk about the common concerns from caregivers about vaccinations and how to respond to these concerns. Finally, we'll discuss the vaccines themselves, which is the medication given. An immunization is the process of becoming immune to the disease itself. So this slide just gives you an idea of the number of cases and deaths per year worldwide from some of these communicable diseases that we're going to talk about throughout this voiceover. So sometimes we get the questions of why we still need these vaccines. Some diseases are still prevalent. So by not vaccinating children, we risk natural and sometimes fatal infections. Some diseases occur at low levels, but if immunizations drop, outbreaks can occur. For example, a few years back, we heard about the measles outbreak in Disneyland in Southern California. Then just a couple years ago, in 2019, there was another increase in measles outbreaks. Some diseases circulate in other parts of the world, like polio, rubella, and diphtheria. And finally, a disease like tetanus, it's not transmitted from person to person, so it can never be eliminated. And the vaccination will always be required to control that disease. And this is why we still need these vaccines today. So in the next couple slides, we're going to talk briefly about some basics of vaccines. We'll talk about different vaccines and how they work, how we make sure that they're safe, and a couple of different systems that are in place to ensure that these vaccines are safe. We'll then focus on the vaccine schedules and why they look the way they do. So how do vaccines work? So basically, vaccines introduce a humoral immune response. So they contain the same antigen or part of an antigen of the bacteria or virus. So they introduce a similar immunological response that occurs following a natural infection. The antigens that were introduced are killed or weakened to the point where they don't cause the illness, but they do allow the body to develop an immune response to protect against future exposures. This response allows for immunity to develop without the risk of suffering from the disease itself. Vaccines also induce a T cell immune response, and they do this through the use of adjuvants. And these enhance the immune system's responsiveness to the antigen in the vaccine. There's different varieties of vaccines. There is the attenuated live viral vaccines and then the inactivated viral vaccines. So the attenuated live viral vaccines include measles, mumps, rubella, varicella zoster virus, rotavirus, and the live attenuated influenza, which is no longer given in the US, but it used to be the nasal sprays that we would commonly see in pediatric offices. There's also the inactivated viral vaccines. These do not replicate, but induce immune response through antigen exposure, and these are seen with the polio, hepatitis A, and influenza vaccines. So, are vaccines safe? Now that we've mentioned many of the vaccines in the immunization schedule, we're going to talk a little bit about vaccine safety and how we ensure that vaccines are actually safe. So, when we give a patient a medication or we perform any intervention, we're always balancing the risk versus benefit. So, when we administer vaccines, we're weighing the risk of giving the vaccine against doing nothing or not immunizing the child and putting that child at risk for consequences of natural infection. Vaccines are extensively tested for both safety and efficacy before they're reviewed by the FDA and approved. Once they're deemed safe and effective, there's additional committees, which you can see on the slide, that make recommendations for administration. Vaccines are continuously monitored for safety using the VAERS system, which is a vaccine adverse event reporting system. So on this slide, you can see the vaccine schedule. This is a recent vaccine schedule, and this is available in many different forms on many different websites, including the CDC website and the American Academy of Pediatrics. It is not necessarily meant to be memorized. As you can see, it's very crowded and contains a lot of information, including the recommended ages for vaccine administration and the minimum intervals. It includes a vaccination for special populations. It's an important resource, and it's really important that you know how to find it and how to use it. So this is the footnotes that accompany the schedule. The footnotes are very important for each vaccine. They provide detailed information about the administration intervals and contraindications for the vaccine usage. This can also be found on the CDC website and within the index of your textbook. Moving on to the childhood vaccine schedule, the infant and childhood vaccines are coordinated with well child visits. The primary series is given at 2, 4, and 6 months of age. At 12 months of age, children receive the MMR and the varicella, and these vaccines are given at 12 months because the immunological response to these vaccines will be blunted by the maternal antibodies that hang around for about the first year of a child's life. Booster doses for these primary series are given between 15 and 18 months of age, and then again before the child goes to kindergarten, between 4 and 5 years of age. Adolescent vaccines are given prior to middle school entry, and they include the diphtheria booster, the meningococcal vaccine, and the human papilloma vaccine. The seasonal influenza vaccine is recommended annually for children, and this starts at 6 months of age. Children may require travel vaccines if they're traveling outside of the U.S. to high-risk areas, and there's also the special population vaccines. These are for people that are asplenics or people with no spleens, people who have nephrotic syndrome, so they'll have some kind of kidney disorder, or those with cochlear implants. In this slide, we're going to talk about contraindications and special situations. So let's first start off by saying that there are very few true contraindications to administering vaccines. One is with acute illness with a high fever. That is a contraindication. However, it's important to know that mild illness is not a contraindication to vaccine administration. There are some true contraindications to vaccines, and these include a true allergen to vaccine components, and another is immunocompromised patients. These patients should not receive live viral vaccines. Children who have been recently given immunoglobulin should not receive live viral vaccines because the antibody in the immunoglobulin will blunt the immune response. Remember that some patients will require extra vaccines, such as those that do not have a spleen, who are especially susceptible to infections like bacterial infections. So they should be immunized with the pneumococcal vaccine, Hib, and the meningococcal vaccines earlier. Okay, so now let's talk about some of the concerns that parents often have. Some parents may be concerned that there's too many vaccines given at one time and given too early. They may have concerns that vaccines contain unnatural components. Some families may feel that the natural disease is a better way to acquire immunity because maybe they all had chickenpox and they feel that it's safer to have that illness than it is to have the vaccine. Some are worried about side effects. Specifically, they may even have concerns about autism. Finally, some may not see the need for vaccines because they don't see the risk from the disease. Overall, we've done a pretty good job of eradicating diseases that families may feel that there is no need to have these vaccines administered anymore at this point. One concern or thought is that having the natural disease may be better for the child. In addition to having high incidences of morbidity and mortality of the natural disease, there are both short term and long term consequences for some of these natural infections. So, for varicella or chickenpox, there's the zoster that's in the person's body and can come out later as an adult or a senior citizen. Measles with encephalitis, even after recovery, the child is still at higher risk for developing encephalitis. And then there's the cancers for the human papillomavirus. So let's talk a little bit about autism. The origin of this concern was from an article in the Lancet that was published back in 1998 by Dr. Wakefield in the UK. It suggested a link between MMR vaccine and autism. The authors claimed that there was a link between the vaccine and a form of inflammatory bowel disease that ultimately led to altered brain development in autism. As a result, there was a new wave of anti-vax in both the UK, where the original article came from, and where Dr. Wakefield was practicing, and in the US. This led to many parents refusing the MMR vaccine for their children. His research methods were shown to be fraudulent, and his paper was eventually retracted and his license was taken away. It has been shown multiple times in multiple studies that MMR does not cause autism, and there's no actual link to this. So, for families with ongoing concerns about the link between autism and MMR, it may be helpful to share with them some of the research that's being done to better understand autism. Research is strongly suggesting that there's a genetic predisposition, and they're now improving screening tools that better detect autism earlier and earlier prior to the MMR vaccine schedule. So, what can we do as nurses to talk to and open those lines of communication with parents who are hesitant with vaccinations? The most important approach is to listen to their concerns and let them know that you're hearing their concerns and not just dismissing them. After that, we can provide clear and consistent messaging with factual information and remind them frequently that their child's health is our primary concern. Parents are very well informed when they come into the well visits, but sometimes the information they get is from social media or chat groups instead of reliable resources. So part of providing factual information is giving them trustworthy websites rather than them just doing Google searches on the internet. So, Google searching, should I vaccinate my child, to see what comes up? So it's important that they have this factual information. So here's a large list of reliable resources that are based on research and facts. So now we're going to take a look at the actual vaccines that provide this immunity. We're going to start with the hepatitis A vaccine and then move on to diphtheria, IPV, MMR, varicella vaccine, Hib, rotavirus, and then finally the pneumococcal vaccine. So we're starting off with the hepatitis A vaccine. This is given through an intramuscular route, and it is a series of 2 doses. They're typically given and are recommended to be given at 6 to 18 months apart. They start off at age 12 months. You cannot do it younger than 12 months of age, and this vaccine is typically given to all children and is recommended by the CDC to be given, but it's especially important to be given to those who are traveling overseas. Next, on the right-hand side of the screen, you'll see there's the diphtheria, tetanus, and pertussis vaccine, commonly called the DTaP. This is another IM vaccine, and it's a series of 5 doses. It's recommended to be given at 2, 4, 6, and then between 15 and 18 months of age, and then again at age 4 to 6 years. The side effects of this vaccine include irritability, poor appetite, loss of appetite, and then commonly you'll see injection site swelling and tenderness. Some very rare side effects, but you should be aware of, and include this in your teaching, include seizures. And this is because of the pertussis part of the vaccine. If a child is known to have this side effect of seizures, there's an option for them to have just the diphtheria and tetanus part. So it's a different vaccination. It's just those 2 parts of the vaccine. It gets rid of the pertussis, and this is okay to administer if they're over 7 years of age. Now we're moving on to the inactivated poliovirus, IPV. This is given either IM or subcutaneously, and it's a series of 4 doses given at age 2, 4, between 6 and 18 months, and then again between 4 and 6 years of age. The IPV, it replaced the old vaccine, which was a live vaccine, and that was an oral route. So this was the old poliovirus vaccine. The main side effect of that vaccine was paralysis, and it wasn't okay if the client was immunocompromised because it was a live vaccine. But note that it still is administered in other countries, just not in the United States. Now, on the right-hand side, we have a different vaccine, the MMR, measles, mumps, and rubella vaccine. This is administered through a subcutaneous route. It's another live vaccine. It's administered at 12 months, and then again at age 4 to 6 years old. Some side effects of this can include a rash that looks like measles, a fever, swollen cheeks, and mild joint pain, but these symptoms are much less severe than the illnesses themselves. Because it is a live vaccine, it is not okay to be administered to those who are immunocompromised. So now we're on to the varicella vaccine called Varivax. This is another subcutaneous vaccine, and it's another live vaccine. It's a series of 2 doses at 12 months and then again at 4 to 6 years. So this was the same scheduling as the MMR, and sometimes you'll even see an MMRV where varicella is included in that. So it is combined yet again. Some side effects of the varicella vaccine include erythema and then a sore arm or even rash at the injection site. And again, because it's a live virus, it is not ideal to give to someone who is immunocompromised. Another note for administering this medication is to not give it if any antiviral drug was given within 24 hours prior to this, and then no antiviral drug should be given within 14 days after the vaccination. Now, moving on to the hemophilia influenza type B, also called Hib. This is an IM vaccine, and it's a series of 4 doses given at 2, 4, 6, and then again between 12 and 15 months. The bacteria Haemophilus influenza type B is an infection of bacteria that was leading cause of meningitis, conjunctivitis, otitis media, and sinusitis in children. So that's what this vaccine is protecting against. Finally, we have the rotavirus vaccine and the pneumococcal vaccine. The rotavirus vaccine is given orally. It starts at 6 to 14 weeks of age, and then it's continued on the well child visits at 2, 4, and 6 months of age. It is a live attenuated vaccine, and it protects against diarrheal illnesses that lead to dehydration. So it's really important for the young infants to get this, to be protected against diarrheal disease, because they have such little reserve when it comes to dehydration. The patients with a history of intussusception and other GI disorders or other severe immunodeficiencies may be contraindicated for the rotavirus vaccine. The pneumococcal vaccine is our last one. There's a couple different forms of the PCV13. This is given at 2, 4, 6, and 12 to 15 months of age. The other form of this vaccine is PPSV23, and this is for children older than 2 years of age and for our special patient population, so those without spleens or those with cochlear implants or other risk factors.